So I'd like to welcome Shamaya Chah, who is a very special friend of mine and also my teaching mentor for the last 20-something years. I met her in 1999. So we've been working together a long, long time. And like I said before, I've heard 100 explanations of the science behind manual therapy. And Shamaya just does it the best. So anytime we can get her to come visit us and explain the science and share her massive amounts of knowledge with us, we're going to take that opportunity all day, every day from now until the end of time. So without further ado, here's Shamama.
Where's the band? Aren't they supposed to be playing or something for me?
They all have COVID.
How you doing? Okay, so I am actually just talking into a big screen that has only my face. I can't get to see you guys. So nice to meet all of you, however many of you are. I think there's 24, it says. So with all that, what I'm going to share is, as I've been teaching primarily anatomy and physiology for the last 40 something years. It's hard to say even those words. It's really kind of important that we just take what we know academically and apply it clinically. So all that about why did I need to know anatomy and physiology? I just need to know where the muscles are. Really, it's about the physiology of the entire body that you need to understand to determine what it is you're touching and the outcome that you desire. So regardless of the diagnosis that someone would have, let me just move this out of the way. Regardless of whatever the kind of diagnosis, we really only treat 4 conditions. Okay, it doesn't matter the pathology, a sustained injury. We treat 4 conditions and 4 conditions only. So we treat a sustained contraction, we treat an increase in tissue waste, a decrease of elasticity, and an increase in fascial adhesions. The reason I have it listed this way is this is how it actually happens in the body. So I know that I speak really quickly, and so far no one has mentioned that. I have my chat on the side here. So if I'm going too quick, let me know. I've done this 4-hour lecture in an hour, in 30 minutes, in like 15 minutes. So I could really do this at light speed. So if you need me to slow down, let me know. Or if anybody has any questions during this time, write them down in the chat and then I'll address them as we take intermittent breaks. Okay, good or good? All right, so let's just talk about that. So what is actually happening? So when we're looking at those 4 conditions, again, I'll repeat it, is going to be a sustained contraction, an increase in tissue waste, a decrease of elasticity, and an increase in fascial adhesions. Again, those are the 4 things that we treat. Now, when dealing with that, primarily we're touching muscles. So when we define the muscle, it's not just skeletal muscle, but there's smooth muscle, right? As well as cardiac muscle. And they all basically have a same mechanism inside the cell. And so for me, it doesn't matter when we go into contraction, whether it's an eccentric contraction, concentric, treppy, twitch, tonic, isotonic, it doesn't matter. The cell actually needs to have energy in order to perform its action, which is contraction. So what happens is that it's going to use a minimum of 4 energies. You're going to use ATP, which is adenosine triphosphate, comes right out of the mitochondria. You're going to be using acetylcholine, which is a neurotransmitter, comes out of the neuromuscular junction, oxygen, and protein. Now, with the minimum of those 4 energies used, whenever you use an energy, you yield a waste product. And in this case, they're all acidic. So all the information I'm going to give you is factual information. And there was this author that was pretty amazing, Dr. Robert Becker, who wrote the book, The Body Electric, back in the 1980s. And he had discovered and substantiated that all those waste products have a positive polarity. We're electric. So what happens is he also discovered that blood has a positive polarity. So if you guys remember playing with magnets, when you have like poles, they repel and opposites attract. So what happens is if blood is the transportation mechanism in the body, bringing good stuff to the tissue cells and taking away the waste product, blood cannot pick up those waste products if it has the same polarity. So there's this inhibition of movement of metabolites. The other thing is another way that we get rid of the waste products through the blood vascular system is through the process of filtration. So that actually happens to be inhibited as well, because when you have blood pushing up a vessel, you have pressure. And then if the muscle is contracting because of pain, it's pushing on the vessel walls. So the example I always give is this. If you had a water balloon and you were to poke a hole in it, well, the water would come out because the air pressure is not equal from the outside to the inside of the balloon. But if you took that same balloon with that hole in it and put it in a tub of water, well, the water would not come out of the balloon because the pressure is equal on both sides of that membrane. So the process of filtration becomes inhibited, and the process of diffusion becomes inhibited when dealing with a sustained contraction and injury. Now I'm going to talk about a little bit further what actually happens and why. We actually have this mechanical process, and it's about a reflex arc to an intense stimulation. So a reflex arc basically is a one-way route to and from the central nervous system. Information comes in and comes back out. So what happens is it's not like the information is going to make it up to the brain for you to make a decision. This is basically a mechanism to protect you if you don't have the ability for sensation. So the example I'll give you is if you put your hand on a hot stove, you don't just like put your hand on a hot stove and say, ooh, that's a little hot. I think I smell flesh. Let me take my hand off. That's not what happens. You put your hand on, the whole upper quadrant moves out of the way. So we have this mechanism where when we have an intense or noxious stimulation, meaning pain, coming into the body, we have a motor response movement to react 10 times or more stronger. We're not really sure about the amount of increased velocity with which it moves, but we'll use 10 as a magic number. So what happens is if you use this visual, please, as I'm going to use my fingers, if this is a nerve and this is a blood vessel, and I'm squeezing because of pain, sensory information comes into the central nervous system and back out in contraction. So here it is now, it's squeezing 10 times stronger than the original sensation coming in. While blood supply is being reduced, the pain is still happening, sensory information comes in and comes back out 10 times stronger or more in contraction. So now the blood supply is cut off. And being that the blood supply is cut off, the muscle is still contracting. If there's no way to get rid of the waste product, we now have a buildup of acid. Ow. So if you have all that acid sitting in there, it's again going to cause the continuous stimulation, so information coming in, coming back out 10 times stronger in contraction. This is what actually sets up the pain, spasm, pain cycle mechanism. Sorry, you can't. Can I please slow down? I'm going to try my best. I'm sorry, I just had like 3 cups of Cuban coffee. I'll do the best that I can. I live in Florida.
Also, just as a reminder, you guys, besides the science on caffeine presentation, we are recording this, and you'll have access to that, and the written attachment is in the chat at 9:18, so you can click on that and download all of the written material that's associated with the caffeinated supplements. Thanks.
Okay, so I don't know, did I fail to mention that the acids that were being formed from using those waste products, this was hyaluronic acid, uric acid, carbonic acid, and lactic acid. So sorry about that. All those waste products have a positive charge. So again, we're looking at the mechanism of the pain, spasm, pain cycle mechanism where there's decreased blood flow to the tissue cells. So when we have decreased blood flow, we call that tissue ischemic. So that there's no blood flow going there. And the definition of a trigger point is an area that is ischemic that when you manipulate it refers pain elsewhere. So, but again, if you take blood out of an organ, you're going to decrease its functionary activity. So in other words, if the tissue is ischemic, but it still has the ability to perform, it just leaves you to be more predisposed for continued injury or an exacerbation of the already injury you have. So what we're going to talk about now is that now that you have the cyclic mechanism of pain going on, your body has this really cool place in your brain called the somatosensory cortex. And what it does is it basically lets you know when something is wrong, by causing the pain alerting mechanism. And if something's really detrimentally wrong because your body doesn't want to die, it's going to tell you, hey, there's something wrong. You need to do something about it. But if something is not detrimental to you, kind of like tension, your body's going to ignore it. So this is really a cool thing that happens, is that, your clients come in and they have their shoulders like this, and they have no clue that they're wearing their shoulders like earrings. So you magic on them and you get them to have their shoulders 6 inches down, kind of laid back and relaxed. And you say, how do you feel? And they're like, pretty much the same. And you're like, what do you mean you're the same? Your shoulders are 6 inches down, you're more relaxed. And they're like, oh yeah, there's not that mind-body connection, that relaxation, because it's not detrimental, is that there's a difference. So it's kind of like if you have a bulging disc or a bone sitting on your sciatic nerve, you're always going to have pain. So you're going to have back pain, butt pain, thigh pain, calf pain, heel pain, all the way down the entire route of that nerve, because and your body will always tell you have pain no matter what. So the reason is that if in fact you lost the use of that nerve necessary to maintain life, your body knows that. So again, when you have a situation that is detrimental to you, pain is the alerting mechanism that your body will use to let you know you need to get the hell out of there or get whatever off of you that is hurting you. But again, when tension happens, it's not detrimental. So your body takes it out of your awareness. If you had to sit there and think every second of the day, oh, my shoulders up, no, they're down. Oh, my shoulders up, no, they're down. You wouldn't really be able to move on and negotiate your way through your rest of the day. So what happens is your body just doesn't allow you to have that awareness. A really good story that we always share as an analogy here, living in the state of Florida, for the last 40 years, when I was younger, we had to wear pantyhose as part of our uniform and polyester pants. I know that's horrific, isn't it? But imagine working outside in the summer in 100 degrees with 1,000% humidity, having to wear that and pantyhose. So as soon as you put them on, your body goes, oh, you got pantyhose on, you got pantyhose on, you got them on, until you wear them all day and you don't know you have them on until you go to take them off. Again, that's a constant chronic stimulation that your brain is having, but it's not going to allow you to be laborious in thinking about it, and just takes it out of your awareness. So it sticks it in your subconscious. Okay. So we're going to move on from there. How's that so far? Okay. Everyone all right with the speed with which I'm speaking now? No one's answering, so I am trying to slow down, and I'm going to then go to what we call the SAID principle. I know I'm going through this quickly, and hopefully this is some stuff that you might have had in your anatomy classes under neuromuscular physiology. Well, what we have now, the SAID principle, is an acronym for specific adaptations to an imposed demand. Basically, it's a homeostatic mechanism. Whenever your body adapts, it's trying to create balance or homeostasis. But when we're getting specific now, we're talking about muscles. What's their function? So we have movement, we have heat production, and contraction. We also have, in fact, some of the other things that are their characteristics. So besides contraction and conduction, also one of the characteristics is elasticity. And that's really paramount, because when you're dealing with muscles, if they've lost their elasticity, you create a vulnerability. So this is the experience I'm going to share with you now. So what happens is, when you're looking at the way that the skeletal muscle fibers are, they line up parallel to each other, and muscles move in the direction of their fibers. It's pretty intelligent design. And then what happens is, when you put a demand too much for it, pop, 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 and then the brain says, not a good idea. Let's repair this way. All right. So when it repairs it fibrotically, and it repairs it with replacement tissue, which is not the same tissue. It is a matrix of less elastic tissue than the original skeletal muscle. So the issue with that is that as you have, this tear, and we do this all the time. When we go to work out, we purposefully rip the muscle tissue, because we know when it repairs, it will repair more densely and harder and make it stronger. The issue is on either side of where that reparation occurred. So it's very much like a stocking. So I'm going to go back to the stocking thing. If we have a stocking as women and wearing pantyhose, or men, and you stretch them, they stretch and return back to normal position. That's elastic. But if we get a run in it or a tear, what we do is we put nail polish on it to prevent it from tearing further. right? But however, that nail polish, when it dries, is less elastic. So if we took that stocking and stretched it, it would then create a rip and a hole around where that hardened area is. So the vulnerability happens to be on the surrounding aspects of the repaired scar tissue. But then the brain says, well, we recognize that's a vulnerability, and I know they're going to go do it again. So let us lay down a strengthening agent at the tendinous attachments. And that strengthening agent is calcium. Why calcium? Well, it's present everywhere in a muscle. It's part of the sarcoplasmic reticulum that when calcium comes out of that structure, the filaments slide and contraction occurs. It's also present in blood, which is part of the skeletal muscle organ as a clotting mechanism. It's also present in bone where the muscles attach as a hardening agent. The other reason why the body will use it is that calcium, and this is interesting, is a natural alkalizing agent. So what do I mean by that? If there's too much acid, the body's going to go ahead and use the calcium that's there to neutralize that acidity if the other organs of elimination are compromised. We'll get back to that in a moment. But important to understand that, your body's going to start to lay down strengthening and inelastic tissues to compensate for the injury or dysfunction at hand. How do you like that? Drink your milk, kids. Only if it's fortified in calcium, right? It's better off with almond milk. You don't really see too many kids hanging off of cow teats, do you? That's another conversation. Okay, so now that we have this stress that's going on in the body, well, what's the response to stress in our body? We actually only have one response, regardless of whether the response of stress is to a spiritual response, a physical response, pathological, sexual, emotional, psychological, it doesn't matter. We have only one response. And that response is with the secretion of the hormone cortisol. Okay, cortisol, is a steroid. You give your body cortisone, what happens is that your body stops producing it. So it's really kind of important to maintain normal levels at all times. So when you guys get cortisone injections, your body stops producing it. If you're on an inhaler for asthma and you need to have a surgical procedure, you need to actually get off of that inhaler for 3 months so your body can then begin to reinstate the production of normal amounts of cortisone so that you can accommodate the stress of the surgery. So this is what happens is when you have the hypersecretion of this hormone, it does a couple of things. I mean, it's primarily used as an anti-inflammatory. However, it also is categorized as a glucocorticoid, which means it has a role in sugar metabolism. When you have higher amounts of cortisone in your body, you have higher amounts of blood sugar, which means you can only use so much glucose. You can only store so much as glycogen. The rest gets turned to fat. So it's very common for people who have been injured or sick or diseased that they gain 20 to 40 pounds within 2 to 4 months based on the amount of stress that's happening. That's pretty common. The other thing is that cortisone will also attach itself. How hormones fit like a lock and a key in their receptors. So if this is a receptor on a cell, this is the hormone and it fits like a lock and a key. Well, it does so. There's the same shaped receptor with white blood cells sticking out of a cell. And the white blood cell doesn't have the ability to recognize another white blood cell, being that the hormone is going to dock right on that receptor site. So basically, it will cause a decrease of immunity. So these are the things that you have to realize that when somebody gets injured, well, how long ago was that injury? Was it a couple months? Did they gain a lot of weight? Are they getting sick a lot? It could be due to all these amounts of increased stress in the body. So the other thing also that happens is that, when you have so much muscle contraction for protection, not just movement. I mean, I didn't really share about that. I shared about muscle movement, but the example about muscle protection is that, I mean, if you're going to get injured, if you see like a sibling coming at you with a punch in your arm, just to like give you a little zest there, you tighten up. And the reason you tighten up is to decrease the pain upon impact. So think about that. If your brain says, okay, increased tension decreases pain, but then if you relax after you've been impacted, now you have increased pain after you've relaxed. That's the second message your brain gets. So we have to try to change that around and stop this process so that we can actually get to a state of relaxation without pain. And that's what our intention is to do. Okay. All right. So now what happens? All right. So you're in the room and you've been massaging somebody and you notice that they turn red. Well, everybody turns red initially because that's vasodilation due to you pushing blood flow into the tissues, and that's a hyperemic effect. The situation, though, is if that redness remains and it becomes hot and swollen after about 10 minutes. Well, then now what you have is an erythemic response. That's secondary. In other words, you have released too many metabolites for those tissue cells to be happy about. So the body is going to cause a secretion of histamines coming out of the cells to actually cause a tissue to be surrounded and raised and hot. When those histamines are released with that new heat that's coming to that area, the body is going to solicit white blood cells to act like little Pac-Men and eat up all the things that you just released. So the importance about this is if somebody is excessively erythemic during your application, it probably means that they can't handle a prolonged application, that you need to shorten it because the body's releasing so many toxins and choosing the skin as the organ of elimination. Now, when is this different? When you're looking at people who are fair-skinned, very, very white people, fair-haired, blonde, redheads, and light eyes, more than likely they have an increased capillary permeability, and that when they scratch themselves, they turn really bright red and stay that way for some period of time. That is also an erythemic response, but based on increased capillary permeability, not based on toxicity. So I just wanted you to be aware of that. The thing about this this erythemia that occurs when you're looking at it in large portions of the body, is letting you know that what you're doing is eliminating a lot of waste product that might be quicker than their organs of elimination can handle. So we want to make sure that we're not going to cause any type of a healing crisis, right? So, like when you learned in Swedish massage in school, that it loses any kind of physiological therapeutic value after 45 minutes to an hour. You don't do an hour and or more than an hour, for any kind of physiological benefit. Yes, it's palliative and it feels fabulous, and everybody loves an hour and a half, 2 hour, 3 hour massage. We all love that, but you might have noticed that if you've done prolonged applications, that the next day they feel kind of snotty, or they get nauseous, they want to throw up, they might have diarrhea, they might have a massive headache. It's because you're releasing too many toxins and they're resettling in the body because there's nowhere for it to have the elimination. So we only want to do shorter applications. When you're doing a manual therapeutic technique, it's based on increments as well. I think you had insurance yesterday and you learned that the body only has 2 body parts, and it's designated into 2 units per body part, which is 15-minute segments. So you get a half hour no matter what on a single body part. And again, that was designed to be able to allow you to not create a healing crisis. Okay, so then what do we do? So now that we see that there's a potential where there's an increased erythema, they might have all these other things going on, we want to, make sure that we could support the detoxification process. Now, we're not allowed to tell them you need to drink a glass of water because that's prescribing. And especially medical massage, we can't do that. We could hand them a glass of water and say, would you like a drink? But we can't tell them you have to drink this. Again, what if they had congestive heart failure or any type of renal disease? Well, both of those would be contraindicated to begin with. But however, if you didn't know or they didn't know, again, we can't tell them to drink water without that being prescribed. So we want to help eliminate or not eliminate, we want to help support the elimination process. So, you want them to be able to increase water consumption. But I always preface my conversation, if I were you and not medically challenged, for water consumption, if I didn't have coronary disease or renal disease, I might increase my water consumption. If I were you and didn't have a liver condition, meaning hepatitis or cirrhosis or any of those kind of things, even mono, I might do a metabolic detox where I'm taking supplements to help pull the waste product out of my body. If I were you and didn't have any coronary disease, I might get into an infrared or far infrared sauna and sweat out the toxins. Or if I were you and wasn't a diabetic, I might take an Epsom salt bath. And I'm going to actually answer this question before it actually comes up, because I know you can answer, but diabetics can have an Epsom salt bath. And the reason is most people who have diabetes mellitus have a water balance problem to begin with, so that they're not putting out enough antidiuretic hormone or aldosterone, which causes water resorption. So if you put them in a bath of salt, the rule of thumb is, well, where salt is, water follows. So you would cause further dehydration of a diabetic that could potentially put them in full-on or systemic body cramping, not very comfortable at all. So also, if I were you, I didn't have any type of irritable bowel syndrome, any diverticulitis, diverticulosis, I might take some chelating vitamins and minerals to help pull that stuff out. So an example of that from a book from Dr. Woolitz called Dead Doctors Don't Lie, he substantiated that 7,000 milligrams of vitamin C and MSM, which is sulfur, will bring you to bowel intolerance and you will evacuate. In other words, your body's going to pull out every metabolite that it doesn't need, and it is going to cause you to release it through the large intestines, which is going to be a violent experience. It's not very comfortable at all. It's rather volatile, serious cramping and explosions out of the back end of your body. So these are the things that happen in the body, you know, when you start to deal with massage and or when people are sick and injured. So now the really good news is when applying science, how can we take care of this and how can we reverse any of these processes? So reality wise, we're basically dealing with muscles. So what we want to deal with is a neurological physiological law. This is called the Arndt-Schultz law, substantiated in the book from Janet Travell, Myofascial Pain and Dysfunction, the Trigger Point Therapy Manual. And, you know, she was really laborious for the first 124 pages in the apropos of muscles about a twitch contraction and the Arndt-Schultz law. Two separate things. So the Arndt-Schultz law states that short stimuli initiate cellular function where prolonged or intense stimuli sedate cellular function due to an endorphin release. So think about that. If those of you who are doing trigger point therapy and you're mashing on an area for 20 to 30 seconds and this tension ball from hell goes flat, you think you did a good job, you know, and then you leave it alone, you come back to another area, and then when you see them the following week, wow, there it is again. So you actually didn't correct the situation, you sedated the situation. So by soliciting a localized release of endorphins. And that pretty much happens after about 20 to 30 seconds that the body's going to secrete those chemicals and sedate that tissue. All right, but it's a chemical and it will wear off. So what we want to do is we want to initiate shutting off the contraction. And this is where Janet Travell was kind of laborious about that. She talked about a twitch contraction pretty much ad nauseum. So a twitch contraction, the definition, excuse me, is when a whole muscle organ reaches a threshold of a stimulus where every fiber contracts fully, and then in the latent period, every fiber relaxes fully. Well, that's kind of paramount information if you want the muscles to relax. So she talked about 3 different ways to do this and showed you how. One was doing this cross fiber friction at the bony attachments for 7 to 10 seconds, and that's inducing a twitch, but the 7 to 10 seconds is the Arndt-Schultz. At the bony attachments, you are initiating the Golgi tendon organs to stop sensing tension. Another way she expressed it was by compressing the belly of the muscle. I'm very sure you won't be able to see, this is my SEM over here, but if I pick it up and compress it, you didn't see or feel that pop because I'm too chubby, but that compression and the pop of that muscle, that will also cause a twitch contraction. And then one other way is by doing deep perpendicular effleurage, like you're plucking guitar strings. Okay. Now, what's really important here is when you have people who are constantly compressing and compressing and compressing and milking the SEM, you don't need to do it more than once if you're going to compress that belly of the muscle. And the reason is, well, one, you're getting the whole muscle organ to contract all the way. In addition, when you look at cellular or muscle cell physiology, if a muscle cell is going to contract, it's going to do so all the way or not at all. All right. So let me just turn that off because that was, I guess I'm way early. And that's okay. So what happens is we just want to make sure that we don't have to be laborious over it and compressing. Okay. And then another way to shut off the muscle contraction is by doing some muscle energy techniques. I know we show you a lot of reciprocal inhibition, but basically it's on the same premise, most of the muscle energy techniques, that when you contract a muscle, the muscle of opposition is on the same nerve supply, it has to relax. So an example is if, let me see if I could show you this. If I contract my biceps brachii into elbow flexion, my triceps had to relax in order for me to do so. Otherwise, the movement would look like this, right? So when I go to contract my biceps, I'm not going forcefully and hard to get every single fiber to contract so that every single fiber of the muscle of opposition relaxes. So just a normal movement. But when we engage a muscle against an isometric contraction, so if I contract my biceps against a force of action, what happens is now I'm recruiting more fibers of the biceps to contract. And then in essence, I'm recruiting more fibers of the muscle of opposition to relax. So how does this help? Well, if you got someone with a psoas that's really, really tight, and the action of the psoas is hip flexion, and you can't get at the psoas because maybe their abdomen is too big, or they just had surgery or something, you would have them do hip extension against resistance. So, and always with a post-isometric stretch afterwards. So when doing this, that's what's going to shut that contraction off without you even to have to put your hands on it. Yes, exactly like PNF stretching. Proprioceptive neural facilitation is another type of muscle energy technique. There's a lot of them out there, Javier. There's PNF, there's MET, there's reciprocal inhibition, there's strain, counter strain, there's position release. There's a bunch of them. So this is information we've had before, but of course, now to take what we know academically and put it into a clinical usage just gives you more armament for you to be able to treat the patient population that you have and give you a little bit more diversity. Okay, so from there, we then have, okay, so we talked about 2 ways to shut off the contraction. So now let's go to the second thing that was wrong with somebody. So we talked about the 4 conditions: a sustained contraction, an increase in tissue waste, a decrease of elasticity, and an increase in fascial adhesions. So right now we just dealt with shutting the contraction off. Now we have all that waste product. Well, how do we get rid of that? Well, Chinese cups are one way to help you. You know, if you guys use the silicone cups or the plastic cups, not glass cups, using fire cups is way too cumbersome. And when you move them, you lose the vacuum very quickly. So, but what happens is when you use a cup, and hang on one second, let me see if I have one here. I know I do. So rather, I'll come back to that afterwards to see if I can get one out for you. But with cups, what happens when you put a cup on, it creates a negative pressure. That negative pressure is going to draw blood to the area. Okay, so where blood comes to the area, it then is now increasing that process of diffusion. When you take that cup off, well, then all that blood flow can return to normal and take away the aggregates of the waste product that has been developed. The other thing that cupping can do when you pick it up and you move it and create kind of like what looks like a bruise, it's actually called a gua sha mark. It's a breaking of capillaries. And when you break a capillary, and this is an ancient Chinese technique, thousands and thousands of years old, you know, I like to do it with cups. It's a lot easier on the body. They try to sometimes a Grasson piece of equipment would work. The lid of a tiger bomb jar would work. A jade stone would work. It's a matter of scraping the body. And when the capillaries break, you don't have to like do it to where you're now creating a bleed. But what happens is when those capillaries break, you're creating the blood vessel to have a negative charge. So the waste product, being superficial, will jump into the blood vascular system to be eradicated out of the organs of elimination. So it's not a bruise, it's a broken capillary. A bruise is in the opposite direction. So you might like to write this down because this is not in the outline. A bruise happens when there's a hemorrhage from the blood vessel diffusing into the tissue. This is the diffusion in the opposite direction. So bruise, blood to tissue, this is tissue to blood. So diffusion's in the opposite direction with creating a broken capillary mark or a gua sha mark. They generally heal within 24 to 72 hours. If it takes longer than that, more than likely the person has difficulty with circulation, could be a diabetic. Yes, you are constantly telling people they are not bruises. Well, now you have the reasoning to go ahead and share with them. Okay, so it's not going to hurt them. But there are contraindications. I mean, if you're going to do that, what can create it to be a bruise is if they're on blood thinners. So something like aspirin, baby aspirin regimen every day, Coumadin, warfarin, Plavix, Lavenox, any of the other blood thinners could potentially cause that. Also, blood thinners are alcohol and marijuana and CBD. So be aware of that if someone is imbibing in any of those on a daily basis, they're going to have thinner blood and have a predisposition to bruising easier. Okay, so another way to get rid of that waste product is with eStim. If your state allows you to utilize any electrical application, always a positive charge coming out of a unit will force the waste product out of the tissue cells. The negative charge will force the waste product towards it. In addition, draw sodium, and where sodium is, water follows. So it actually causes a deconcentration of the tissue waste. Another thing to do would be contrast applications, alternating hot and cold to act as a vascular pump. Pretty much if something is red, blue, or purple, it's still bleeding, so you don't want to do any kind of treatment in that area. But if it's yellow, green, and brown, it's on the healing end, and you could, knock yourself out all day long. All right, so now that we've dealt with ways to get rid of the waste product, now we're going to deal with the fascial adhesions, which also deals with elasticity, okay? So well, you could do a fascial ringing, and this is different. The fascia work that I'm talking about is very different than myofascial release. This is not a John Barnes application, and I'm not negating that. I think his application is fantastic. It's outrageous, and it really does very deep work, and the slower you go, the deeper you go. But what he does in positions of opposition at a 45-degree angle of penetration, and doing it so slowly, does not allow us to stay within the confines of Arn Schultz. So I'm not stating it's not good. I'm just saying that in a medical massage application, when you only have a finite amount of time to work on them, either a half hour or an hour, to utilize that whole technique on a complete body part will not allow you to affect as many tissues as you might need to in that short amount of time. So hopefully what we're sharing with you is an economy of motion where you're treating the most amount of tissue in the shortest amount of time. So a fascial ringing would be like when you have a vertical axis as in a bone. So if I grab the tissue and squeezed around it and had that constant tension, well, now I'm ripping all of those little itty bitty fascial adhesions that might be in between the muscle fascicles and the individual cells. And then I take it further. You're not really going to get much movement on this joint. It's a pivot joint at one end and syndesmotic at the other. So, and then you could do it in the opposite direction. Imagine if you had like a piece of corned beef, and I'm sorry, I'm going to go there, but if you had a piece of corned beef, which is a big fat muscle, and you twisted it, well, all those little itty bitty fascicles are going to fall. And those fascicles or little itty bitty threads are muscle cells, and that chewy white surprises is all the fascia and or adhesions. So that's what we're ripping when we do that. Another way is to do a fascial bend. So you can actually, I'll try it on my arm so that you guys can pick up the tissue and you can either twist it or bend it in opposite directions. Sometimes when I'm using both hands and it's hard to do that, I'll pick up and I'll bend towards me and hold for 7 to 10 seconds with a constant tension, and then take it further. And then again, 7 to 10 seconds, and then take it in the position of opposition. You can also pick up the tissue and turn your body with it, or make an S position, whatever you need to do. However, I don't do it quickly. That's just going to piss somebody off. I always do it with purpose and intention. So I maintain my constant contact tension along with the direction of or vector of energy in which I'm stretching. All right. And then always continue with, again, 7 to 10 seconds. So you could do that in a lot of ways. And then my favoriteest way, because this is corrective, is a fascial kinetic. A lot of you know it as pin and stretch. And if you've taken anything with Dr. Michael Leahy, who was one of my instructors in active release technique, again, it's a very fancy pin and stretch, but a fascial kinetic is what we're looking at. And that is what's going to actually rip the adhesions that occur to prevent the sliding surfaces from sliding on one another. You know that you have, when you're looking at the layers of tissue, it's really kind of important that you get this. You know, you have the epidermis, the dermis, and subcutaneous tissue, which is a lot of fascia. And then along with the external fascia on the muscle, which would be the epimysium, and then around each fascicle, the perimysium, and then around the individual muscle cells, the endomysium. Same stuff, different place, but we have where like this tube within a tube within a tube within a tube, and we really want to be able to allow these sliding surfaces to slide, and they get stuck often when we have injury and or if we don't move. So one of the things that we can do, again, I'm going to come to this position here. So if I want to adjust my brachioradialis, if I'm in just extension here, if I compress and have a tension that is proximal to my elbow, if I then bring my thumb or extend my forearm, whatever is happening underneath my thumb as I'm stretching and ripping the tissue underneath. So that would be a fascial kinetic. It's basically a pin and stretch. The thing that I've learned about that, and a lot of people don't discuss this, but you don't want to be on a single body part or area for more than 8 repetitions, because then what you're going to do, and this is according to Dr. Michael Leahy, you will create an injurious healing mechanism. An injurious inflammatory mechanism rather than a healing inflammatory mechanism. And then the very last thing we'll talk about is compression versus entrapment. Okay, so compression happens from an osseous or cartilaginous structure that's sitting on a nerve. So people generally lean antalgic away from their pain. So if this was a vertebrae and here's a vertebrae here, this is the foramina where the nerve comes out of. If in fact it was encroached upon, people lean away to open up that facet so that there's not as much pressure on that nerve. So leaning antalgic is generally a way to understand that they will probably have a compression. Typically, the pain associated with that or the symptoms are going to be systemic from the root. So let's say you have compression of the sciatic nerve, that is called actually sciatica syndrome. It would give you back pain, butt pain, thigh pain, calf pain, heel pain, all the way into your foot. But if you had entrapment, which is from scar tissue or muscle tension, you will be leaning more towards your pain, kind of like a rubber band, being elastic. If you stretch the ends away from each other, that becomes very tight. If you bring them closer together, it becomes looser. So when people are leaning towards their pain, more than likely it is an entrapment. And typically the entrapment of the sciatic nerve is known as piriformis syndrome. They would have their pain would be compartmentalized. It'd be back pain and butt pain, or butt pain and thigh pain and calf pain and heel pain. Generally, it doesn't go down the entire route of the nerve. And there we have everything done in light speed without indications and contraindications. So I am done with that portion of my speech. Is there anything else you'd like me to discuss, TC?
Fantastic. You covered a lot in a short amount of time, but it was recorded. So if you guys have questions, okay. We have a few more minutes until our scheduled break time. So you can go ahead and fire those questions off. We have her for a little bit longer. Elizabeth and Lisa said trigger point release. Is that
a question?
Yeah. Okay. With the trigger point release, how long do you hold the trigger points for?
Okay, well, that's a wonderful question, because I'm going to say something that's probably going to make a lot of people mad. I don't do trigger point therapy, and the reason is it's a symptom of a sustained contraction. Typically, what I would do is I would take care of the fascia around that area and then shut the contraction off with any type of twitch contraction, and there will no longer be a trigger point. So if you're only treating the trigger point because as it's a symptom, it's not really a condition. So again, I would really the only two techniques one really needs when dealing with skeletal muscle is a fascial technique and a way to shut the contraction off, and there will no longer be a trigger point there. But typically, most people will hold their trigger point for 20 to 30 seconds. And the reason they're doing that is not because they're moving the stuff out of there. It is because they're causing an endorphin release. And again, it's a chemical, so it will wear off in about 4 to 6 hours. And when they come back, their situation is again. Now, I am not mentioning, or I'm reading this, sorry, I'm not stating that trigger point therapy is not a good application. It is only a single technique that is utilized in encompassing multiple other techniques. Did that help you? And then
Yes, yes, that did. Thank you.
You're welcome. And then it says, you mentioned that trigger point is we manage to release the muscle, then the weak trigger point is back, it's just sedated. So would the solution truly resolve the sustained contraction and work the areas around? Yes, as I just said, Javier, it would be to shut the contraction off as well as take care of the fascial adhesions around that area.
If I may add too, I think maybe this will clear some things up. Is one of the manual therapy techniques that we teach within this program is neuromuscular therapy, or the application of the science of neuromuscular therapy. The way that I use it within my practice is more of a assessment technique as far as referral patterns, because it has been well documented that the referral pattern from these areas in the muscle are predictable. I don't necessarily use neuromuscular as a technique very often to heal the tissue, but we do use it a lot in assessment. We use David Kent's flip charts. So they do have predictable enough patterns that help us determine where some of that muscular issues could be coming from. But we don't use neuromuscular therapy in and of itself. So basically the same thing you said. Yeah.
Right. Can I just add to that? Okay,
Absolutely.
so typically looking at those referral pain patterns, typically when you're looking at a trigger point, it follows the entire muscle organ itself or a common fascial membrane. What I saw on his chart is showing a common fascial membrane, or if you're looking at Travel's chart, it goes more on a common muscle length of the muscle organ itself. Now, when looking at neuromuscular therapy, that has gotten so much notoriety as, okay, learning NMT for this body part and that body part. It is merely different techniques that are designed to shut off a neuromuscular junction, which is pretty much any technique. They have been categorized as most of the, I'll say, people like Paul St. John, Nemo, Che Tao, Judith Delaney Walker, all coming in from the same aspect from Judith Delaney Walker, from Janet Travell. About the trigger point, but again, it is a symptom, and developing or using a trigger point application is only a single neuromuscular therapy technique. So most of the techniques that are out there are neuromuscular therapy. However, in the confines or the constraints of using it in medical massage is where the difference comes in. Anyone else? But yeah, and also one other thing where I just want to mark the differences here, where, I'm generally categorized as old school, meaning that I've been around for 40 years or more. So in dealing with medical massage, prior to doing any type of assessment, wasn't necessary for me because the doctors were doing the assessment and the diagnosing, and all I had to do was treat. That's very different now because a lot of doctors just go to a PT or send you to a PT and say assess and treat. So even though we're not PTs, it's really important that now when you're looking at the information that TC is sharing, it's about assessing, not guessing, so that you're not just using your skills on a population that have a prescription, that you're able to utilize all your skills on people, and that you might even be able to refer to a physician based on your findings. So really, assessment is key when using any of these techniques.
Thank you. Thank you for that reminder. And, as far as being old school is concerned, what you have to say is very, very needed, very relevant. And I just want to, again, congratulate you again. Shamaya was recently inducted into the Massage Hall of Fame. After 45 years of service in our industry.